My name's Shelley Horn. I'm Executive Director of System Redesign and Clinician Engagement with Department of Health and Wellbeing. And I'm fortunate to be in a position to be leading this work. And I really enjoy it because what it does is let me step back from the everyday. And I guess if people get their sense of what happens in health from the papers, then they think that most days, every day, we're chasing our tails trying to sort things out. This piece of work lets a group of us stop for a minute and take a breath and actually think about what is it that we need to be thinking about for the next 5 years, or as Chris said, 10, 15 years out, so that we can start to do some things now that make sure we're pointing in the right direction into the future. So we started that work, and as a result of the first piece of that work, which is really a huge piece of work just to analyse data, we gather information from all sorts of sources and we analyse it to start to tell us things about our population's needs into the future. So my job today, I know it's probably a little bit boring, I get excited by it, but the rest of you probably don't, is to give you a little bit of context and background so that you can take that into the conversations that you'll be having at your tables later, so that when you're thinking about the future exciting advancements, you've got a bit of background about our population to hold that to. Okay, so we started the data collection for this piece of work probably around mid-2017. And it's a bit of an indication of how far we've travelled just in our thinking about what this is about, that the title for this document has moved from being a clinical services plan to a health strategy, to a health and wellbeing strategy, as we've gradually lifted ourselves up and tried to have people understand that what we are not trying to do is work out what every hospital should be doing into the future and telling them what that is in a great deal of detail. We're trying to lift ourselves up completely from there. I think potentially looking back far enough, history might tell us that as health has developed with technology, what we've done is go from people getting care in their communities, in their homes where they live, to as technology built us equipment and new fancy things that could be used, and the workforce developed its expertise, that we started to build very specialist buildings and we put people inside of them because that was the most cost-effective way to get people the care that they needed. But what it meant was the community then had to move, and if you can't access the building, then you can't access the care. I think the exciting thing for us now is that the new advances in technology are reversing that almost and making it possible now for people to again receive the care that they need when they need it in their own homes and in their community. But having said that, my job, that's the exciting bit clearly, my job is to tell you about the data. But first of all, I'm a public servant. We need principles. They're things that guide us in what we do. I'm not going to go through them for you. These are draft. Everything that we've worked on so far is draft. All of the work that we do today will help us form a draft document that will then be the basis of our consultation going forward. So this and everything else that we've worked on so far will become part of the consultation, and you'll have an opportunity to comment on these things. But we've been using these to guide us for the time being. So when I want to talk about our population in South Australia, we use the population projections that are developed by DIPT. So what they do is use the ABS census information, but then they apply to it the local knowledge that they have around local, overseas and interstate immigration, and also information about new land releases and development agreements and all of those things. So we believe this is the most accurate information to be used, but having said that, they're projections. So what is produced is high, medium and low series. We base all of our planning on the medium series. So here we go. What you can see here is light to darker colours is the amount of growth in our population going forward. So I think it's very clear that you can see the highest rate of population growth is in the northern suburbs that are serviced by the Lyell McEwin and Modbury hospitals, and the services that are provided by Narlan and the peri-urban service delivery from Gawler and the Barossa around those areas. You can also see some infill work that's happening going up into the western parts of Adelaide in the centre, and the growth that's happening in the peri-urban areas. So we need to focus on those things when we're thinking about developing our services going forward. It's also important to note the change in our age structure going forward, and Tim talked to us about this. What you can see is the over 65 age group continuing to increase as we go forward. And between 2019 and 2031, it has the largest increase of all of the population groups, so larger than 0 to 14 and 15 to 64 combined. So we expect to see almost another 100,000 people in that age group going forward. When we gathered data and evidence, we were very fortunate that a big piece of work that had been sponsored by the Faye Fuller Foundation, that was undertaken by SAMRI and Taxi, had been completed and had been published in May of 2018. It was a very large piece of work that included gathering of all of the South Australian related information that they could find that had been published, as well as that they did semi-structured interviews for groups of people, and they used the SA Health Omnibus survey to try to gather information. And what we've done is utilise a lot of that information, and I'm using it to provide you with some snapshots today. So for men, for adult men, you can see they're about 50% of our population. I guess we know that, but you can see that the rate of growth again is in the over 65s, and that for our Southern Adelaide Local Health Network, they have the highest rate of growth for men in that age group. Men are more likely to have cardiovascular disease and cancer than are women in the same age group. Older men have the highest smoking rates. You can see, and when you see women as well, we don't eat a lot of fruit and veg. We know that we should. But you can see the life expectancy for men in South Australia is equivalent to the national average. For women, again, a lot of ageing, again in the south. We eat a little bit more fruit, a little bit more vegetables than men do. Women are more likely than men to have asthma, arthritis, osteoporosis, and a mental health condition. And our life expectancy is just slightly below the national average. Key issues and priorities for children, and I'm aware we've got some experts in children in the room, so this is probably just skating across the top of what they know about this population group, but we do have low growth in our children's population, and it is focused in the north and in the centre of our metropolitan areas. We have more low birth weight babies than the national average, but our perinatal mortality is lower. So I think that speaks well for the services providing to that age group. Our vaccination rates are around the Australian average. There's some other interesting things that we found when we looked at children, one of which is that given that there's a lot of focus on child death, that the rate of child death in South Australia is reducing by around 11% per annum, which I find incredible. But it is not reducing as quickly in the lower socio-economic areas of our community. We've also, the findings from the Faye Fuller report was that about 25% of children have been identified as being developmentally vulnerable on at least one, possibly more, of those factors that they measure. So I think that's important for us to know as we go forward. Key issues for older people, increasing population across the board, but still focused in the southern metropolitan area of Adelaide. older people more likely to have arthritis, diabetes, osteoporosis, etc., and dementia. Dementia is increasing in prevalence across our population, and what we know about people with dementia is that they are also likely to have multiple comorbidities. So for us in planning for a group of people who increasingly with their dementia may not be able to look after or think about how best to look after themselves, that's something for us to think about as we're planning. Aboriginal Torres Strait Islander people, the very significant, it's not an issue, it is a fact that the age population profile for Aboriginal people is very different to the rest of our population. They are much younger. So the average age of our Aboriginal population is 23 compared to 40 for the non-Aboriginal population. We know that the Aboriginal population suffers heart disease and stroke at an earlier age than the rest of the population. There's also a fact that I'll drop in here that comes from one of the slides that's a bit further on, which comes from the interviews that were conducted for the Faith Fuller Foundation, which found that racism and cultural competence are a very significant issue across our community and in our health services. And I think it's an issue that we really need to think about as we're planning going forward. We need to be sure that everything we do is addressing in a positive way the disparities that currently exist, because I think it's quite easy to, in planning at a whole of system level, to lose sight of some of these populations and inadvertently do something that actually increases disparity. So, for example, access to the internet, if you're going to be using it to deliver all sorts of education, people need to be able to access it, and sometimes we know that they can't. Issues for the cold population are listed up there, but the standout factor for me is that the information available starts to become very limited. Research is focused in on some of our newest migrants and newest arrivals. So what we know about people who've lived here for a long time and who are ageing, we don't know so much about those groups of people, and we need to if we're going to be planning for them. Similarly, with this group of people, there's very limited information available outside of what's available here. And I'm thinking that in the next few years, this information will become much more available to us. Issues relating to people who live in rural and remote areas. Interestingly, if you look at the data that's available, it would suggest that they have worse health and a greater risk of poor health than their metro counterparts. If you ask them about their health status, they tell you that they're very healthy. So I'm find that that's tends to be a positive way that they view themselves. We know they have poorer health outcomes relating to chronic disease, higher incidence of smoking, high risk alcohol use, overweight and obesity, and mental health proportionately greater burden, but their health-seeking behaviours are reduced compared to others, might be due to access. And what we know is that there's almost no information. There is no information specific to South Australia about people who are leaving the justice system. So what we've got is national information that tells us they're at risk of poorer physical and mental health than the general population, but nothing specific to South Australia. Now, just very quickly, if I look at analysis of our internal data, and I'll jump over the population and demographics because we've had a look at that. Quality of life and mortality rates, South Australia self-assesses its health at the second lowest across all of the Australian states and territories. We have a mortality rate that is around the national average. So the first probably is showing us that we have above average rates for risk factors and for chronic disease, and so that may be what it is that people are self-assessing. We do know that we have, our smoking rates are very favourable compared to national, and what I think that tells us is what you can achieve when you have a fully integrated, multi-agency, multi-government level approach to a risk factor. If I look at patterns of demand, just really quickly, and people would be experiencing this for those here who are working in the acute part of the system, inpatient growth at 1.6% per year, split across overnight and same day, highest growth in country, and we have significant, like 2% growth, just above 2% growth in ED presentations a year. Those growth rates are not as high as are being experienced at the moment in some of the eastern states. So what that's doing is bringing our relative utilisation rate down overall. It's interesting to note that after a period of private health insurance coverage increasing, it is now decreasing. I wonder how much that's got to do with now the health insurance companies really starting to stratify their market and start to remind women of my age that they don't really need obstetric cover anymore. And so as people start to dig into things, they start to drop off with their health insurance. We know that income and remoteness are barriers for using for internet access. Low socioeconomic groups have high rates of hospitalisation, and that the growth in overnight activity is highest in our metro areas, and that it is focused predominantly on adult medical, adult surgical, and respiratory. So the chronic disease end and very much the older population need. Just a word in relation to what we've found here. This is analysis based on our system staying exactly as it is now. The point of our strategy is that our system should not stay exactly as it is now, so we should be seeking to move some of these things as we redesign parts of our system. But we do at the moment, compared to national average, have relatively high rates of hospital-acquired complications and unplanned readmissions. If we don't change anything, we will need to continue to increase our supply of inpatient beds by about 2% a year. The highest growth clearly is in Narlan and the peri-urban areas. In terms of our workforce, we have higher numbers of medical and nursing staff when compared to national, but much lower numbers of allied health, diagnostic and administrative support people in our system. And our average cost is higher than the national average. Just a quick look at the gaps we can see so far between need, demand and supply. Our relative utilisation rate is around the national average, and for people who've been in the system for a long time, you might remember we've always talked about South Australia being higher. We're now settled at that national average. Highest utilisation of public services is in Narlan and in country, which also happen to be the two areas that have the least access to private services. We know the number of emergency department patients who are being seen on time is trending downwards, as is our response to the people who need elective surgery. So there's starting to be signs that we have to do something different. Just quick overview of the outcome of the Health Omnibus survey. So this is a survey where people are asked, and this is their own opinion of their health. 35% of them rated their physical health as the most important issue that they had, and 11% cited mental health. 25% of the people surveyed had found that their health had limited their ability to work or to undertake moderate activities, and that 17% had said that depression or anxiety meant they couldn't accomplish all that they wanted to. I think they're messages for us, if we can lift those figures, that we can impact on the economy in South Australia if we can have people able to work at their most productive, then whatever it is that they're doing in their society and their community will help. It's interesting to note, interviewing people and then reviewing the data where the areas were consistent, and there was consistent agreement across support for prevention activities, support to focus on mental health, ageing, dementia, obesity and access to health service. Variance between what the literature says and what people reported relating to unless you were in the middle of raising children, having babies or being pregnant, people don't necessarily raise issues around the support that women need in terms of mental health and supporting children. A subgroup of people talked about drug and alcohol issues, and the people in rural and remote felt that their health was a much higher status than what the literature suggests that it should be. Semi-structured interviews, here are the themes. I won't really go through each of them. I've highlighted the racism issue. I think it's important to highlight people are seeing that evaluation of the health system is counting things. It's not looking at outcomes. We need to change that. Focusing in more on the community and finding ways for people to access service remains important. And lastly, as a part of the work that we've done so far, we've had a preliminary conversation with our own senior clinicians and LHN executives around having a strength-based focus, and we themed up all of the comments that we got from that group, and we've put them into 4 key themes, and you can see those there. I think they're starting to head us in the right direction, and then the information that we get from today will start to really tease out more where we need to go from here. I'm hoping that's a really quick race through some of the information that we've got to give you a base for the conversations that we're about to have, focusing on how we use the new technology to address some of those issues.